the risk or symptoms of heart failure is critical, because once heart failure, the SGLT2 inhibitors are beneficial. In terms of data with GLP-1 receptor agonists, I didn't show the data. Currently, the meta-analyses reflect a neutral outcome for prevention of heart failure with GLP-1 receptor agonists. But in established heart failure patients, which was only one trial, small, a sample size of 300, the NHLBI sponsored study, when used in sicker, recently hospitalized heart failure patients, GLP-1 receptor agonist was associated with trends for worsening. So in established HFrEF patients who are sicker, we're a bit concerned with GLP-1 receptor agonists to be used for the heart failure indication, but overall they appear to be neutral for prevention of heart failure.
Thank you. Next question is about omecamtiv, and in view of the galactic heart failure trial showing more benefit in advanced patients with the lower EF, what do you think the role of that drug should be currently?
First, let me touch on showing benefit in advanced, because subgroup analyses sometimes get misperceived. We see heterogeneity in subgroup analysis with a only in the EF less than 28%, meaning those subgroups appear to have a differing benefit with a higher level of benefit in lower EF. The other subgroups did not reveal heterogeneity by the p-values for subgroup analysis, but in the NYHA class 3 and 4, the confidence intervals appeared on the more benefit side. With these very subtle findings with subgroup analysis, I think we need to wait for the FDA to see whether the omecamtiv would be approved for use. If approved for use, the profile of safety, being able to use all the way down to a blood pressure of 85, actually creates an opportunity for us specialists for advanced heart failure, where sometimes the limitation is the blood pressure. In the very advanced stages, as we all know, the blood pressure is one of the limiting factors, and thus being able to use it also for inpatients as well as outpatients in sicker populations, I think creates an opportunity. In those who have high or good blood pressure, where I could optimize other medications, I would be optimizing the life-saving therapies first and optimize them to the optimal doses that were used in the clinical trials. After which, if I am unable to use the standard therapies, then for omecamtiv, that can come as an option. If I'm unable to use any of the other agents due to hypertension, it comes as an opportunity. And I think we need a little bit more data in advanced heart failure to see. And more importantly, as you know, we do not have any agents for the palliative patients. We send them home with home IV inotropic therapies. It would be so good for us to be able to use some of these agents that have a reasonable safety profile and potentially benefit in improvements in symptoms, though the quality of life didn't make it with a borderline p-value, and efficacy. And I think that's another patient population that hasn't been tested in clinical trials that the clinicians are so eagerly waiting for.
Yeah, it's a great point. It'll be nice to have options in the patients that are more sick, absolutely. Next question is from one of our preventive colleagues, Dr. Kershaw Patel. How do you recommend deciding which patients should be screened with natriuretic peptides to evaluate heart failure risk?
Great question. I think the screening strategies need to be based on the population, right? At the VA, most of my patients probably would have an abnormality when screened because they have CKD, they have advanced age and comorbidities, and that the threshold of what I'm going to consider as abnormal or a pathway that is going towards heart failure. So the screening concept needs to be formulated for the population studies. But overall, right now, the study that I quoted, the STOP-HF trial, screened patients with diabetes, hypertension, coronary artery disease. And majority of the patients had one or the other, not all of the three. And I, right now, knowing with the benefit of results, what we have seen for prevention of heart failure, with a magnitude of 35% risk reduction for prevention of heart failure with SGLT2 inhibitors, would be screening diabetic patients, would be screening patients with CKD, would be screening patients with a perhaps hypertension cluster with CAD. And I think we need a risk scoring very similar to what AHA-ACC did for atherosclerotic cardiovascular risk calculator. And there are currently studies looking at a risk calculator that is going to look at the demographics to determine whom we need to do the additional biomarker screening.
And particularly if it changes our approach and therapy.
Yeah.
Certainly.
So I think we have time for maybe just one or two brief questions. One is, should we consider treating HFrEF patients with a mixed etiology pulmonary hypertension? So for those in the audience, those that have a high wedge but also have a high transpulmonary gradient, or those under consideration for heart transplant with elevated TPG with vericiguat?
Great question. Possibly yes. We don't. The problem is the subgroup analysis in Victoria, because our advanced biventricular failure patients with high TPG, transpulmonary gradient, tend to be the ones that are the sickest and tend to be the ones with the highest level of NT-proBNP levels. The signal we got from the study, yes, it was a sick patient population, but then this whole NT-proBNP subgroup analysis, actually Justin Ezekowitz did a subsequent analysis looking at a continuum of analysis of which patients or what cutoff the NT-proBNP appeared, or patients over which they didn't demonstrate benefit, showed it very consistently that over a certain level, over 5,000 or even higher, does not seem to benefit. Mind you, it didn't look like there was adverse outcome, but that creates a question of maybe the pulmonary vasodilation concept, as you know, in advanced biventricular failure is a tricky concept in heart failure. So I don't want to right now confer the results of what we know from PPH studies with vericiguat to the secondary pulmonary hypertension seen in HFrEF. We did not get that safety signal and or efficacy signal from the Victoria trial. What do you think, Barry?
Yeah, I think right now, I think it's too early to use. So I agree with you on waiting for more data. So I think if I may ask one last question, just to kind of close it out. I know we're running on time, but just to go back to the polypharmacy, and certainly concerning for our patients. And I have a small minority of patients that will tell me, give me the latest and greatest drug. I want everything you can throw at me, which is great. But most of my patients don't do that. Do you think we need big data using AI, using genomics, transcriptomics to help guide us on how to individualize and personalize all these wealth of therapies now we have to offer?
Partially, yes. The reason is I think we're missing out on etiology a lot, especially in the non-ischemic patient population. We don't seek the etiology most of the time. We just do standard therapies, but as we learned from amyloidosis, we're missing a lot of the, truly the genetic causes and or opportunities for treatment. And if this were to be simplified, because ordering a genetic test right now with a genetic counselor and so forth has so many layers and it's difficult. And even, coordination of care, trying to capture all the data, microalbuminuria may be recognized by the nephrologist. And for me to order that, understanding the concepts of what do I do with this, I think AI at that point with a learning health system where it may say, your patient has this contraindication and may benefit from this and has this, let's say, variant in terms of genetic and may not respond. The non-responder is a big issue. A genetic enhanced response is a great opportunity. And I think these are truly becoming a little bit complex, but would allow us to work better. But the thing I'm also going to say from the other side of the coin, oncologists are not waiting for AI to do very coordinated, molecular targeted, individualized precision medicine. When people use the word precision, it sounds esoteric and or sounds as if it requires a very high-tech AI technology. In essence, it just says, treat according to specific causes. And I think we need to embrace this now, not waiting for some, very advanced EMR and or technology, but embrace. The smartwatches, the Apple study for AFib is very intriguing, right? And how we're going to utilize that in heart failure, along with, further detection of risk and treatment. I think these are all happening. Telehealth is here. You already are doing it. We're doing it. So how do we combine all these data points, and who's going to be watching all this? Probably will need to be AI, because we will not be able to absorb and capture all this data. And we're already recognizing the necessity to utilize the scoring apps and so forth being so useful in decision making. And ACC and AHA has done a tremendous job in creating these little tools that helped clinicians to be able to absorb a large scale of data and change that into implementation.
Well, Dr. Bozkurt, what a pleasure having you this morning. And thank you for sharing your wisdom and your experience in this field, which is truly amazing. A lot of new developments, but I think application science is still very important for us to move the needle from our patients. So really exciting. And thank you again for joining us.
Thank you so much, Dr. Bozkurt. It's great.
Thank you. It was a pleasure to be with friends and colleagues and former mentors, and thank you for the opportunity.
Wonderful.